Welcome to another episode of Genetic Counseling with Dr. Aparna Dhar. हमें वो दो पिछले एपिसोड में बहुत कुछ बता चुकी हैं. हम आज के एपिसोड में डॉक्टर अपर्णा से पूछते हैं व्हाट हैपेंस अगर एक पेरेंट का फादर या मदर का पॉजिटिव जीन होता है. पेरेंट्स आर स्कैर्ड एंड व्हाट शुड दे डू? प्लीज एक्सप्लेन अस एंड एजुकेट अस, डॉक्टर अपर्णा.
Wow, that's a very tough question, to be very honest. It's very difficult explaining because I can understand the concerns, right? The questions that come into a parent's mind. So, first step, if a parent tests positive, don't panic. The knee-jerk reaction immediately wo ek घबराहट आ जाती है, my children. Don't panic. Second step is जब आप positive आते हो, तो आपका जो जेनेटिसिस्ट है या जेनेटिक काउंसलर है वो पहले आपकी पर्सनल हिस्ट्री, आपकी फैमिली हिस्ट्री को देखता है और समझ लेता है कि आपके फैमिली में क्या ट्रेंड है. और मैं ट्रेंड क्यों बोलती हूँ, क्योंकि अगर आपके 1, 2, 3 जनरेशंस में कैंसर हो रहा है, कौन से कैंसर, क्या एज है जब पहली बार डायग्नोसिस हो रहा है, हम ये सब समझ लेते हैं. फिर हम आपकी जीन को देखते हैं, आप कौन सी जीन के लिए पॉजिटिव आए हो, वो जीन का क्या इम्प्लीकेशन है चाइल्डहुड कैंसर्स में और एडल्ट कैंसर्स में, उस जीन का क्या कोरिलेशन है, वो आपके कौन से कैंसर्स के रिस्क बढ़ा देता है. जब हमारे पास ये सब आंसर्स आ जाते हैं, फिर हम आपके बच्चों को देखते हैं. Ideally, genetic testing is only done for those who are over 18 years. 18 and less, we do not recommend genetic testing just because having that sort of information can be psychologically challenging for a child and kind of puts them under unnecessary pressure. Now, let's look at the type of genes that a parent can test positive for. Some of the common genes, like we're talking from a breast, male or female breast cancer, ovarian cancer, pancreatic, prostate, BRCA1 and BRCA2 are the two most common genes that we see in this particular cohort of patients. So we know that these are the cancers that are associated with it. This is what increases their risk. What's important to know is these are adult onset cancers, which means it happens at a later stage in life and not as young as 5, 10 years old. So just because a parent has tested positive, it does not mean the child will test positive too. These sort of genes follow an autosomal dominant pattern of inheritance, which essentially means that the parent who carries that affected gene also carries a healthy normal gene. So imagine that you've got a parent who is the affected parent and their BRCA1, BRCA2 gene is in BRCA1 gene, let's use that as an example, is in the color combination of red and pink, in which that red is affected and the pink is healthy. The other parent who's unaffected has the BRCA1 gene in the color combination light blue and dark blue. Now, children get one copy of a gene from their one parent and another copy from another parent, and that's how we have two. So this parent who has the red and pink, which is the affected parent, and you've got the other unaffected parent with dark blue and light blue. When they have children, the combinations that can be passed on to the child are the red can team up with the dark blue, the red can team up with the light blue, pink can team up with the dark blue, pink can team up with the light blue. 4 combinations. Out of these 4 combinations, only one combination goes to the child. So now I know that red is defective in the parent. So the red and dark blue and the red and light blue, it's a 50% chance that the affected gene can be passed on to the child. And there's a 50% chance that the unaffected gene, which is the pink and the dark blue, the pink and the light blue combination, that can be passed on to the child. So step 1, you have to know that you're not definitely 100% going to transfer this to the child. Now let's assume that this is a BRCA1 gene, so we know it's associated with adult onset cancers, which means that it happens in an later stage in life. It happens at a much more over the age of 18. Your child is 26, 27 years old. At this point, we would recommend genetic testing to them because these are grown-ups. They can make educated, informed decisions about themselves and about their options that will be presented to them. If they test positive, then because I'm using BRCA1 as an example, so because it is BRCA1, we immediately chart out a surveillance plan. We start educating them how to look for symptoms, how to do something as basic as once a month, a self-breast examination, and ultrasound of the ovaries, a simple blood test called PSA for prostate, for something as simple as, which comes much later, for the pancreas. So we start educating them about the different types of symptoms that are there, what they can do. We give them lifestyle management, stress management options. We educate them about diet. We educate them about how our environment influences and increases our risk. So that's done in a positive setup. If the child is negative, then we just leave the child because that child falls under the general population risk. And this is the general format we use when a patient is, when the parent has an autosomal dominant, or when it has one of these genes that are associated with adult cancers. Now, in some instances, we see genes like TP53. TP53 can also affect children. So in a case like this, where the TP53 again follows autosomal dominant pattern of inheritance, we start testing children. And that's one of those rare cases. Another rare instance is, let's say that a parent who has that BRCA1 mutation is married to another parent who has the same BRCA1 mutation, because they're either from the same family, coincidentally, both parents are carrying a mutation. Then in those cases, because we know, remember, it's red and pink and now red and blue, there is a combination of red and red that will come to the child. So in this particular combination, I know my child is at risk. This couple's child is at a risk of having cancer at a very, very small age, at a very young age, and is at a high risk. And in those rare instances, we actually go and test children. So it boils down to, what is the gene that the parent has tested positive for? What are its implications to the family and to the parent themselves? And then we make these decisions. Now, remember, when you're doing it for children, it is the parent who becomes in charge. Anyone under the age of 18 is a minor, so the decision is on the parent. But in some cases, we do have where parents insist that even if it's adult onset, they want to test in young individuals. But we very strongly advocate that this is not the standard of care, and it's not really recommended. But with adults, what we also see that I want to add is, going forward, there are reproductive options that are in place that, in a way, you can kind of eliminate this going into the next generation, which means your child has it. Somebody who's born with that defective copy, we can't do anything. But the next generation, through pre-genetic implantation, we do have different options that are available for the next generation or the upcoming generation, where we can try and avoid this hereditary gene being passed on to the next generation. So a lot of options, but again, it's talking to a specialized person versus Dr. Google in this particular case.
तो थैंक यू डॉक्टर अपर्णा. जो हमें समझ आया वो ये है कि अगर एक पेरेंट की, एक मदर की स्पेशली ज़्यादा चांसेस, क्योंकि हम ब्रेस्ट कैंसर देख रहे हैं बहुत यंग वुमेन में, अगर फॉल्टी जीन आता है, we need not get scared. The message that Dr. Aparna is telling us is, there's so many combinations, let's not get scared, और घर बैठ के डरिए नहीं, let's go and meet our genetic counselor and let's educate ourselves. फिर हमें समझ आ जाएगा हमें करना क्या है. And as Dr. Aparna said, पेरेंट का फॉल्टी जीन का मतलब ये नहीं है कि बच्चों को पक्का ही ये तकलीफ आएगी. राइट डॉक्टर अपर्णा?
एब्सोल्युटली. और मैंने एक बहुत इंपॉर्टेंट पॉइंट मिस किया कि अगर आपके पास फॉल्टी जीन है, इसका मतलब ये नहीं आपको 100% कैंसर होगा. इसका बस ये मतलब है कि जो जनरल पॉपुलेशन है, आपका रिस्क हायर है उससे. इसमें तो ये गारंटी कुछ नहीं हम दे रहे कि नहीं आपको पक्का कैंसर होगा। हमें पता है कि आपका रिस्क है, पर हम कॉन्फिडेंस से नहीं कहेंगे कि आपको 100% कैंसर होगा। So that's a very important point that I should have started off with, that it just puts you at a higher risk versus the general population risk.
वही बात, हमें एजुकेशन मिलना जरूरी है। सो एवरीबडी आउट देयर जो ये वीडियो देख रहे हैं, आई एम श्योर डॉक्टर अपर्णा डिटेल सिंपल एक्सप्लेनेशन ने हम सबको हेल्प किया है समझने में कि व्हाट डू वी डू अगर गॉड फॉरबिड हमारा एक फॉल्टी जीन है। थैंक यू डॉक्टर अपर्णा।
Thank you so much for having me. An absolute pleasure. Thank you.